Good afternoon, and welcome to today's webinar, Increase Medication Communication HCAHPS Scores Among Your Senior Patient Population. My name is Leah Brooke. I'm with Get Well Network, and I'll be the operator on this call. Before we begin, I'd like to take you through how to use the GoToWebinar platform. All attendees are in listen-only mode. If you'd like to ask a question, you simply type your question in the question box, which is located on your navigation pane, or you can click the raise the hand icon. You can ask a question during any time during the webinar, and we'll take questions in the last 10 minutes. And of course, if you experience any technical trouble, you can just message me in the chat box. It's my pleasure to be joined by 4 hosts from our Get Well Network community who are leading the way by tailoring their medication education programs in their elder care units by using Get Well Network's interactive patient care. On the line with us from Carilion Roanoke Memorial Hospital, we have Kathleen Boudreau, VP Clinical Risk Management and Interactive Patient Care, Zach Widener, Interactive Patient Care Manager, and Pete Flynn, Unit Director for 10 West. And we have Dennis Harris, Nurse Manager for 6A from Christiana Care Health System. It's really an honor to have you present with us today. To walk you through a roadmap for today's discussion, Kathleen, Pete, and Zach will kick us off to share how Carilion Roanoke Memorial Hospital improved medication communication HCAHPS scores by better leveraging Get Well Network into the medication teaching process in 10 West, an acute care for the elderly unit. Next, Dennis will discuss how Christiana Care Health System is improving nurse compliance of medication side effect education using Get Well Network on 6A. Finally, we'll conclude with Q&A. It is now my pleasure to turn things over to Kathleen.
Thank you, Leah. I'm Kathleen Boudreau, as Leah said, and I'm the Vice President of Clinical Risk Management and Interactive Patient Care here at Roanoke Memorial Hospital. Very happy to be here with my colleague, Zach, who is the Interactive Patient Care Manager here, and Pete Flynn, who has been very successful in his rollout of the Get Well Network and education treatment on 10 West. Carilion Clinic. Oh, there we go. So Carilion Clinic is a nationally ranked integrated healthcare system. We're not for profit. We're in Roanoke, which is Southwest Virginia. We've got about 12,000 employees and over 1,000 employed providers. We have 7 hospitals. The picture that you're seeing here is our flagship hospital, which was a level 1 trauma center, which is Roanoke Memorial Hospital. And in there, we've got a children's hospital. Again, we've got neurotrauma, very active ED, and a number of sites. We have a number of urgent care facilities, home health agencies, retail pharmacy, wellness center, and even patient transportation. You can see that's our helicopter there flying over Roanoke Memorial. We also have a college, Jefferson College of Health Sciences, that has nursing programs as well as occupational therapy, physician assistant, EMT, and I think healthcare administration. And then we partnered with Virginia Tech to develop the Virginia Tech Carilion School of Medicine and Research Institute. So we're very active as a teaching hospital as well. We're nationally recognized. I know that anybody on the line knows all about this, but we are wired and we are a magnet, and we've worked hard to get Beacon Awards. Our home health is very, very progressive, and also has the Home Care Elite Award. So now I'm going to turn this over to Pete Flynn, who is the Unit Director over 10 West, which is our acute care unit for the elderly. Pete?
Good afternoon, everyone. As Kathleen said, my name is Pete Flynn, Unit Director for 10 West, which is a 28-bed acute care for the elderly nursing unit. One of the biggest goals and opportunities that we have is we work diligently with other allied health professionals to promote and prevent functional decline in those patients that are hospitalized. one of our big focuses is to make sure that we can return our patients back to their home setting or setting they were in prior to hospitalization without any loss of independence, similar, hopefully, to the conditions in which they came into our facility. A little breakdown demographic for our nursing unit. As of fiscal year 2016, we had an average daily census of 23.95, average length of stay of 7 3/4 days, and about a third of our patients that were mentioned in the previous slide, a third of those folks go home at the completion of their hospital course. A third of those folks are discharged to a short-term rehab facility, and that last third are individuals that are identified for long-term care, skilled nursing placement, or acute memory care for those individuals that have Alzheimer's or dementia. At the tail end of 2015, the inpatient care manager for Get Well came to me, and we identified that we had a lot of work to do across the board with raising our unit-based HCAHPS scores. And so the question posed to me was, if you could focus on one area, what would you want to focus on? So that August of 2015, we identified medication teaching process was likely to be one of our biggest holdups for our patients and their families. So the inpatient care manager and I met. We mapped out what that process would look like, mapped out how we would measure improvement in the initiative through HCAHPS scores, and identified that we would utilize Get Well Network in that endeavor. So our goal was to improve the medication communication in the hopes that we would increase our HCAHPS performance. Identified very quickly was that our population we were serving, those folks 60 and above, the health literacy related to medication was not nearly as high as we had wanted it to be. So we chose to use Get Well Network to simplify and boost the impact of our medication teaching efforts with our frontline staff. It was introduced to my nursing staff in one of their monthly staff meetings at the end of August, knowing a new fiscal year was upon us in October, that we would start this process. So the inpatient care manager came to my nursing unit and went to all staff meetings and got buy-in from staff starting September 1 that we would start utilizing the Get Well Network to teach our patients about one medication per shift, utilizing the tools within Get Well Network for communication about medicines. So this is what you're seeing in front of you is a snapshot with the Get Well dashboard up on the television screen. What the inpatient care manager and I instructed my staff to do was for having our staff click on the See My Medications tab. Once they clicked on the See My Medications tab, the box would pop up here, would populate where they could select a medication. This was the alpha phase of the project, where the staff would actually type in the medication. With our bidirectionality with our EMR, we now have the opportunity for staff to enter in the last 4 digits of the patient visit number, eliminating the staff to type in any medication. Now patients' medications, if they are actually prescribed, populate for staff to do the teaching point. So the nursing staff reinforce these teaching points by sending the teaching point either to my chart or emailing patients or their caregivers that we're going to be following up at home. The green thumbs up on the screen there indicates that the teaching point was complete and that it would be sent to my chart. And of course, the envelope with the plus sign was staff's opportunity to email that information to patients and or their families. So After receiving verbal buy-in, September 1st, 2nd, and 3rd came, and very quickly saw that I had zero utilization for this new process. At that time, I held some meetings with my frontline leadership on the nursing unit to encourage utilization. And on September 4th, I think my nurses sent me a message loud and clear where there were 124 teaching points. I believe throughout the course of that 24-hour period that they must have communicated 4 or 5 medications to each patient to make up for lost time. Initially, at our time of launch, nurses were very timid. Southwest Virginia, we have a remarkably humble population, both of patients and of healthcare workers, and there was a big concern of confrontation, being too pushy with an initiative. Originally, staff were talking to the patient, saying, we have this medication for you. I'd like to teach you about it. Identified that our scripting would have to change to, your doctor has ordered a new medication for you. Let me teach you why this is so important during your hospital stay. And then another lesson, valuable lesson learned with any new initiative is the initial group of naysayers on my nursing unit, where the perception was, this is great, you're increasing my workload, I'm here for, 12 hours a day, and I have a lot to do, this is just another thing. So at that point, by the time I started getting feedback for staff saying, I'm not sure I want to do this, we were about 2.5 weeks in, and so I reminded my staff very simply, what would Florence do? I reminded my staff that I did not create the concept of educating patients. Wasn't willing to take credit for that, and we've been educating patients as long as modern hospitals have been in place and caring for individuals. So once staff kind of heard that message, the workflows started to become streamlined. I saw more staff adopting that process and becoming more, integrating that more into their workflow. With that being said, to review some results with you, Zach Widener, our inpatient care manager.
Thanks, Pete. This is Zach. So we're going to talk about results a little bit from Pete's initiative and all the hard work that the staff of 10 West put in. In the first 3 months of running this pilot, from September 1st to November 30th, the nursing unit averaged 32.3 med searches per day. So that was before our integration. So we were touching every patient. As Pete mentioned, there's 28 beds on the unit. We were touching every patient at least once to really achieve that goal. And after the first 3 months, the nursing unit started to see improvement in unit-based HCAHPS scores. 7 of our 8 HCAHPS dimensions that we were tracking saw positive variance, so we saw an improvement basically across the board after this initiative went live in that first quarter of use. Utilization of the medication database continues to rise, so this wasn't kind of like a quick shot. This is something that's Pete and the staff of 10 West have been able to sustain for over a year now. As you can see on the chart on the right, the number of medications viewed has peaked out into about 3,000 in a quarter. So they average over about 1,000 a month of teaching points for their patients. So health education utilization has dramatically risen for 10 West. They were in the 40% range for health utilization, and now the average is in the 80s and 90s every month, and it peaked out at 93%. So knowing we touched almost every single patient, with that really being driven through those medications. To kind of further highlight the outcomes that this initiative really had a major impact. As a whole, all other units combined at Carilion, excluding 10 West, the med teaching utilization was just slightly under 2%, whereas Pete was slightly over 61%. So in the same time frame with that utilization, Carilion saw a 1 percentage point increase in their medication communication HCAHPS scores, whereas Pete saw a jump in 29% increase. And as you can see, Pete's score was 79%, and the hospital as a whole was 66%. So he was jumped up dramatically in his unit, but was also ahead of the hospital as a whole. And as we mentioned, there's benefits beyond medication communication, so focusing on that one dimension in HCAHPS, that med piece, and using Get Well throughout, we saw improvement across the board. So nurse communication, people feeling that the responsiveness of the staff and communication in general just really improved. It was something that kind of drove home a positive result for all of our patients. You can see here our nurses' HCAHPS score in August was 58%, and it moved to 89% in January. This is specific to 10 West, the PEDS unit. And the overall rating for PEDS unit in 10 West was 54% before we started, and in January it was up to 77%. So HCAHPS scores from the third quarter were compared to the fourth quarter, so kind of pre-intervention, actually the first month of intervention, to the first complete quarter where the intervention was deployed. And we ran a p-value test against the scores that were achieved in those quarters and saw a p-value of 0.027 using the Fisher's exact test method. So we saw statistical significance in the improvement in our score. It was a very positive result that Pete's been able to maintain for a year. I'm going to turn it back over to Pete to talk to you guys about the keys to success in maintaining use.
Thank you, Zach. So one of the big keys to success is unit leader buy-in, identifying that for as far as strategic initiatives go, that when you are going to start something, you have to be willing to see it through to completion, through the ups and downs. One of the concerns that some of my colleagues here at Carilion have is that we have so many new initiatives. You know, how do I know what's going to be flavor of the month versus long term? And so the key to this for me was that this is something that, regardless of what else comes down the pipe, I'm going to have to continue to put this on the front burner, as it were, and to make sure that this initiative continues to take precedence in our daily workflow. I also needed my frontline leaders, my frontline clinical team leads, to take accountability for this process as well. I have 24/7 nursing unit coverage from my frontline leadership, and so I needed to know that even when I wasn't in the building, that this initiative was still going to be tracked and followed through. Follow through, as we said, is important. You know, it takes 30 to 60 days for something you do to be ingrained and become practice. So doing this initiative for 10 to 15 days and hoping it would stick wasn't going to be the answer. Continued follow through. We do have ebbs and flows in the process, depending on unit census. But one thing remains consistent is all the staff that are utilizing Get Well Network for this purpose and new staff that are hired in understand that this is an expectation of how we practice. It's how we do business. And knowing the resources that you have at your disposal, whether it's through the inpatient care coordinator, through senior leadership administration, through Kathleen, our chief financial officer and CEO, knowing that you have buy-in for these initiatives from those individuals. So going forward, one of the things that continues to help us with our sustainability is my nurses receive weekly updates on our HCAHPS scoring dimension. Usually that information populates either on a Sunday or a Wednesday through our vendor that provides our HCAHPS scoring data. So staff are receiving that weekly update, real-time feedback, how many patients answered always versus no or sometimes. My staff receive managerial feedback on the Get Well usage on a every 24-hour basis. Our frontline leadership does. I can extract this data through Get Well internet portal there, and email that information to my frontline staff so they can benchmark where they were from a previous 24 hours or how they did over the weekend. High utilization for my unit, as Zach mentioned, we've been averaging in the 80s to 90 percentile range for usage on a monthly basis. That certainly is incentivized with, pizza parties, ice cream socials, things like that to engage staff. Staff that are identified as high utilizers, they may receive a gift card for coffee or something to that extent, and it is published in my weekly update to staff who our high utilizers are for the process. Another, staff have demonstrated very well that they are able to successfully manage this process. We are looking at other opportunities for utilization of Get Well. One of our new initiatives is focusing on making sure that the care area is quiet at night, utilizing Get Well to that extent as well, which is a relatively new initiative for us within the past month and a half. We have, Zach and I have reached out and have had routine meetings with other departments in the hospital that provide direct care to patients to encourage and get those individuals, those unit directors, get their buy-in, get their units comfortable utilizing the teaching tools and communication through Get Well. We are starting to see a resurgence in usage, and other nursing units are becoming more prominent in their daily and weekly usage.
Thank you.
Great. So,
hey, Dennis, take us away.
Thank you. Excellent. Appreciate being able to follow Carilion's presentation. I think there's a lot of similarities between our organizations, our units, and the challenges that we found and the solutions that we found in the Get Well network to meet our goals. Just to tell you a little bit about Christiana Care. Christiana Health System is the second largest employer in the state of Delaware. We have 2 hospitals, the main Christiana campus where my unit is located, Wilmington Hospital, and then we also have a standalone Middletown ED. The ACE unit 6A at Christiana is a 39-bed medical unit. We specialize with patients usually 70 and older, so our age range is a little bit higher. We will dip down and take patients sometimes 65 and above to help our system out with flow. So at Carilion, you guys talked about what would Florence do. I like to use this slide, and I say, what would JJ do? For those of you that don't know who this gentleman is, this is JJ Watt. He's a defensive end for the Houston Texans, and unfortunately he's injured this year. But I like to blend role models from the world of nursing and outside of nursing for my staff. And I love this quote: success is not owned, it's leased, and rent is due every day. And we use this with the start of this project and with our unit in general, just to re-emphasize that what we did yesterday and the successes that we had last month, we can't rely on those successes. It needs to be an all the time, always process for things to be successful. What I'm going to talk to you about today, I really think is about leading these sorts of projects. And we're a unit that focuses on the elderly, but I think that these lessons can be applied not just to elderly patients, but to any population. We used our success as a unit with the Get Well network to springboard into other successes and change our culture in the unit. And one of I think the biggest successes that we had after finding our groove and finding success in doing something that no one thought that we could do well, which was med education and the elderly, we then translated that into our second success, which was to dramatically drop our fall rate and go over 115 days without a fall on our 39-bed unit. I'll tell you about 80% of our patient population comes in with something related to a fall. Either they directly fell, syncope, stroke, or renal failure and dehydration. The last time that the unit had gone 30 days without a fall, I think you had to go back to 2010. But during this period last year, we went 115 days. So I think success breeds more success, and we use the Get Well Network as a opportunity to grow that success. The other thing that I think this slide speaks to is that everyone is accountable for the professional practice. And we looked at this not as a project, not a flavor of the month, not a project of the month, but we're going to change the way that we operate. We're going to be a little bit different. And everyone who comes onto our unit, whether you work here full-time or you're coming through orienting or per diem or just pulled for one shift, you need to know what the expectations are. We're going to hold everyone accountable to them, and we're going to breathe success up here. So here was our opportunity for improvement. At baseline, we started with only 7% utilization of the My Medications section in the Get Well Network. And we had seen this. I'll give you a little background. I had started as the unit manager in March of 2014. It was about a year later in April of 2015 where we really started looking at the data from the previous year. And as nurse managers, we were looking as a system at our Get Well Network data, and I was seeing a lot of stagnant numbers. It wasn't taking off. I said, somebody has to do something differently. And I'll introduce you in the next slide to my team. It was a combination of an RN3, someone on our clinical ladder who's a step higher than your average bedside nurse. They showed more system-wide involvement, who said, I see this as an opportunity in an area. So we coupled together and got council members involved and took this to the next level. There were a lot of excuses and a mindset of this population cannot do this and cannot have this education. They won't retain this education, or they don't want to go on a computer screen, or they don't want to watch they don't want to have that TV turned on. It's a bother to them. So we turned that around on our staff, and we turned it into a practice issue. This is more than just passing out meds. This is going to be how we as nurses practice. Regardless, we're going to start to see ourselves as educators and really high-functioning nurses. And we want to make sure that every time we are doing things the right way. And it's not just giving meds to a patient, but it's educating them on their medications. Our goal originally was to go from a 7% baseline to hit that 50th percentile or above. So this is the team, and the advice that I can give to you is to have the larger the team, the better. The main champions on this project, I'm going to point out Fanta Schwartz, who is a member of our Education Council. They're listed on the right-hand side, and those other Education Council members. So having variety in skill set there, folks from different shifts, folks of different ability levels, year one nurses and folks who are seasoned vets, 10 years or more. They helped really drive the practice. Does the manager need to drive accountability on some level? Absolutely, and needs to help make this front of mind. But what's going to happen on the weekend? What's going to happen in the middle of the night to make sure that this is truly functioning? It's buy-in from the frontline staff. A little bit of background on the unit too. I'm going to key in on that third bullet right there. We used an opportunity of having a large amount of turnover on our unit as an opportunity to do a reset and a culture change for our unit, and turned what could have been a negative into a positive. We had a large number of turnover. As we as an organization, as a unit, said nursing needs to function in a different way. We need to be data-driven. We need to be patient-driven, and we did a little bit of house cleaning up here, to tell you the truth. Some people were on board with that, and some people were not on board. And I think we're in a better place now because we went through that process. But we took that opportunity to also start orientations with people the right way and build med education into their practice from the very beginning. It's difficult for someone who's been practicing one way for 5 or 10 years to start to do something new, and there's stress that's associated with that. But if we can start this on day one with you, and you know no different, that every time I give a medication, I use it as an opportunity to pull that screen up for the patient, go over those medications with that patient, then it's just part of my normal practice. What a great opportunity to create a cultural change. So there on this slide, you'll see the My Medication score was 7.8%. We were waiting for patients to go in and find this by themselves, and maybe here or there we would go in and access it for patients. You know, when we did, we had very low utilization. Patient would see between 2 or 3 medications on there if they were bored and happened to go in or curious, go in and see it on their own. But we needed to change this as something that we're going to let the patients discover on their own to something we're now going to give our nurses permission and control of the Get Well network during that med pass to say, it's time for your 8 o'clock medications. I've got your medications here. I've got the Get Well network right here too. I'm going to pull it up, and I'm going to focus on a medication this morning. Our outcomes and goals, we wanted to improve the My Medications usage to 50%, increase the overall number of medications that patients were seeing. So not just logging in one time for the sake of logging in, or they did it once, but making sure that this was done consistently. Increasing the total number of login sessions, and then making sure that there was real value in this, and ultimately that it was driving our HCAHPS scores, and we're seeing the correlation. So what did we do? Those staff members that are part of our education council did one-on-one education with each staff member. We needed to make sure that first they knew how to access the My Medications tab and felt comfortable with that, and then second, that they understood the expectation for our unit, which is any nurse, if you're practicing at the bedside, whether it's your 8-hour shift or your 12-hour shift, each nurse on every shift with every patient who's alert and oriented, you need to pick at least one medication. You don't need to go over every medication, but focus on one medication using the Get Well network and educate during that shift. You'll go in, show the patient the med, go over the side effects with the patient, and then on the next slide, I'm going to show you a tool that we used for a while that it helped give us from management a sense of whether or not this was happening. We didn't have to go into the rooms and pull it up ourselves. The nurse would then just simply write, DH, which are my initials, Lovenox, and the date when it happened. So they'd write their initials, what the medication was, and the date. We didn't want to overburden them with documentation, but we needed to take a quick and easy look to see where's this happening and where's this not happening. This is the form that we used. We kept it simple: medication, date, and initials. These were handed out with every admission. The nurse knew to put this on the clipboard, and these were collected at time of discharge, and our education council worked with them. They sent recognition to staff who were high utilizers with this, and really everybody at some point became a high utilizer. You have your folks that buy in right away, and some people that need a little bit of encouragement doing it. But I'll tell you what really drove this practice was management making sure and having discussions with folks that this is really professional practice, and this is the expectation of what we've got to give to our patients. They deserve it. They need to know about their medications. Our organization and our unit values this too. So working here, we need you to value it as well. So part of my job is doing patient rounds every day. I go in and speak with my patients and patients' families. So I'll go to each district and approach the nurse first, who's appropriate for me to talk to. My next question is always, how's med education going? Or let me look at the forms to see how it's going. So I will pull these out. They're right on the clipboards, and a lot of times I'll just put my initials and the date and a smiley face or great teamwork, putting positive motivation on there, and letting my off-shift staff know that I'm looking at it as well. So in the very beginning, this was pretty intensive. It was, I'm trying to look at everybody every day, and then gradually as this became built into practice, we were able to pull back. And I can explain later, we've actually moved away from this form because we feel that it is so ingrained in our practice, but that was important. Did I occasionally get a, hey Mary, how's med education going today? It's going fine. Okay, how many oriented patients do you have? I have 4 oriented patients. How many have you done med education with? today using the Get Well Network? One. Well, one, one isn't the expectation, but you're working a 12-hour shift today, and it's 3 o'clock. So I know you've got 4 o'clock meds to give. You've got some insulin to give later on. I'm going to be looking tomorrow to make sure that that's complete. You know the expectation. You know what we're trying to do as a system and for our patients, and we need all the oars moving the right direction. It took a couple of those conversations, not very many, but then we got everyone on board, and it really changed our culture. We also made sure that we build it into our culture in other ways. Our orienting nurses, our preceptors, we were very upfront with them about we want people coming through our unit practicing the same way that we do so that this is an always experience for our patient all the time. So whether it's someone directly hired to our unit or maybe someone floating through in a residency program that may spend some time here but may not end up working here full time, if you are passing meds on our unit, this is what we expect of you. We talk to our nursing instructors who are having their students pass medications on our unit. This is the expectation. So let's make this experience with a student passing med and the instructor there the same as the nurse. And we talked about it with our pooled nurse and per diem staff. Direct feedback, giving praise, and also constructive feedback was positive. And another key to our success was having quality. We have quality and safety huddles at the start at 7 o'clock in the morning and at 7 p.m. in the evening. It's about 2 minutes, but we'll have discussions about, it's a lot of quality and safety information, but we always focus on patient experience as well. And we rotate the topics, but we talk about Get Well Network quite frequently in those huddles. They're led by the leadership team. If it is a time when I or the assistant nurse manager are not there, then our off-going charge nurse would lead that conversation. Everyone comes to the front desk to start their shift. It's really been a huge driver of change on our unit. Rather than having 13 staff who go off to their little islands to work, now you've got a team that comes together, gets a big picture sense of the floor, and goes into their day knowing the goals. So, hey team, at 7 o'clock in the morning, last night we had 12 new admissions on the unit. We've had a lot of success with Get Well Network. Let's keep it up, and let's really focus on making sure we get those new admissions with their med education early in the morning, in case any of them are in and out in less than 24 hours. Because what we asked our nurses to do was each shift to, if you have to give if there's a med pass, you have to do one med with that patient during that shift. But it's the nurse's choice of when they want to do it. If they have 5 oriented patients, they don't need to do Get Well Network med education and document that with all 5 with the 7 o'clock or 8 o'clock meds in the morning. They can be selective. I'm going to do these 2 patients with their 8 o'clock meds. The patient in the next room, he's been here for a while, had a lot of med education already. You know what? He's got something that's different for him at noon. I'm going to focus on that and do my documentation then, and my other I'm going to do at 1600 in the day. So they didn't feel they had some control in it. They didn't feel overburdened or I have to do this all at the busiest point in my shift. So we give them some freedom there. But those huddles really drove the practice. Everyone knew the expectation. It reinforced the education that we did early on, and it gave it good direction. So here are our results. This is the percentage of patients using my medications. So you see the slight bump in April. We started this project the last couple days, in the April 20th and beyond. So we started to see the increase then, and then we really saw it once we hit May, June, and July. And I will tell you that these numbers have grown even since then. We are consistently in the 70th to 80th percentile. Now, we specialize in, we have a lot of patients with either delirium or dementia. So 100% isn't an appropriate number for our unit, but we've told our staff that even our patients who do have dementia or who are delirious, that you're looking for their family to educate and have that encounter with them and log that. We've modified that original form that I showed you where the staff would put their initials, the date, and the medication that they educated on to include 2 other columns. Either the patient was not appropriate for They were confused and not appropriate for education because that's real for some of our patients. We don't see families or caregivers, and they are completely not oriented. That's not the patient that we're going to focus on for the education. They're not able to receive. Then we added another column in there that we educated family in there. So, as staff saw that we were looking at this, that this was something important on my unit. I have nurses I have a great nurse, Priscilla, who would come around, and I'm just looking at the documentation. And hey guys, at 10 o'clock in the morning working day shift, I know that it's not all going to be documented for today yet, but I'm looking back the last 24 hours, and I could see the wheels spinning of Mr. Jones isn't appropriate, but I know the wife's coming in this afternoon. I'm going to log them in together at 4 o'clock in the afternoon and cover the antibiotics with them. And that's a great, spot right there, then and there, to reinforce that good work with that staff member. So the average number of medications viewed by patients, that went up substantially as well. Our average length of stay is a little bit shorter. We're about 4.5 days, but we did make a significant jump, and that has continued to rise and stay consistent. And the total sessions of my medications, you can see back, 41 in a month going up to 742 in a month. It really became not just a project, but a whole process change and practice change for our unit and our nurses. So our analysis, I think we really, because there's a delay in HCAHPS data to your real-time practice. So we looked at our July data, having really started the last couple of days of April, but May was our first full month. So we looked at our scores for July and compared them. So we saw an overall increase with medications from 56 to 83%. Nurse discussing medication side effects from 35 to 73%, and nurses telling patients what new medications were for from 76 to 93%. Path forward and next steps. We continue to share out our monthly successes at our unit huddles. It's something that we talk about, on a daily basis where we need to be at, but our system reports back scores for the individual units every month, and we try to celebrate that success. So we let them know, hey, we were 75% last month. That's a great place to be. And as a nurse manager, I find the value in talking to patients during my rounds. We have a program that the hospital subscribes to where we, as nurse managers, will go in and ask, 7 or 8 questions to the patients. And there is a question about have staff talk to you about medications and side effects. I follow that question up with my own question. Have the staff also logged you in to your TV screen, to your Get Well network here, and shown you your medications on the screen and covered them that way for you? And that's a great way in the moment for me to realize that is still happening. And major lessons learned, focus in on that second bullet. Patients verbally state that the Get Well network has been beneficial towards their understanding of their medications. I think that's the biggest success in being able to reinforce this with staff. Going from an original state a year and a half ago where folks said, patients don't want this, they're not interested in this, we can't do this, they can't remember this, to now patients finding joy in being engaged by the Get Well network and engaged by their nurse, and the fact that someone practiced in a certain way to take their time to do things the right way with their patients. So that has been even a non-measurable huge satisfier for our patients, and we share that with our nurses as well. Hey, you don't always get a lot of thank yous in nursing. You don't always get thanked by every confused patient as well. And when folks do come to the hospital, they're at a stressful moment in their lives. But recognizing those times when they do tell us that this made a big impact on me, or I didn't know this about my medications before, or I think it's really neat how when a new medication is ordered, it's fed right into the system, and I can see that. There have been huge benefits for that, and I think it's enlightened a lot of our new nurses and allowed them to see themselves in a different way.
Thank you, Dennis. And thank you, Kathleen, Pete, and Zach. That was such a fabulous presentation. Before we take questions, in case anyone needs to hop off early, I'd like to provide our contact information. If you are new to Get Well Network and you'd like to learn more, here are the ways you can let us know. You could fill out the 4-question survey. It will pop up as you exit the webinar. We always appreciate feedback, especially feedback for our presenters. You can contact your client services manager, and you can always contact me. So at this time, we'll now take questions. To ask a question, go to the question box, which is located on your navigation pane, and go ahead and type in your question. We'll take questions in the order they're received. So it looks like we have our first question. How difficult is it to get buy-in from frontline staff?
I would, Pete Flynn, Carilion Clinic here. I would say that the initial buy-in from staff that have practiced in healthcare for a length of time greater than 18 months. I think there's an inherent challenge there because you are impacting the way they envision their practice going, how they envision their day-to-day workflow, and so that's where, from my experience, where the challenge for buy-in came in. But I had to stick with it. I had to reiterate the point that education for our patients is nothing new. I think Dennis brought up a really good point about your patients that may have dementia or Alzheimer's, and the staff member says, oh, this is, completely erroneous. There's no reason I should be doing this. Yeah, they may have dementia, but their granddaughter doesn't, their spouse doesn't. So you look to that next in line caregiver, and that's one of the things that I had to really convey to my staff to really get their thinking about what their job role is in patient education and what that looks like. So the initial buy-in was a challenge, but I think continued pressure in the right direction to do the best thing for the patient. I think that really is what all staff that get into healthcare are really geared to do. And so I think once they kind of started thinking in those terms, that the buy-in over time became less and less arduous and more accepted by staff.
And I've shared with my staff here, I was a bedside nurse. I came directly from a bedside nursing role to a manager role, and I struggled as a bedside nurse thinking this seems like the flavor of the month or the new thing, and there's always something coming down the pike. So I reasoned with my staff, and I was upfront with them of, I'm going to ask you to do very few things, and never am I going to ask you to do projects. The things that we are going to select to do on our unit are going to be professional practice items that will drive outcomes, drive patient experience, key into those nurse-sensitive indicators, be good for you and good for the patients, and they're not going to be something that comes and goes. They're going to be things like, quality bedside shift report, purposeful hourly rounding, and med education. Those things aren't going away anytime soon. So let's learn to do those right. We do these things right, they're going to keep those projects away.
Thank you. Do you have a champion on the floor?
I would, my frontline leadership, my clinical team leads, all 6 of them are my frontline champions. All of my bedside nurses participate in the daily activity of medication teaching, but I do have 6 individuals that help me with the unit overview and day-to-day operation that are my go-to champions.
For us at Christiana, at least on my unit, we have one of the RN3s who was involved in the Education Council that helped us kick this off. She has some time built into her schedule, just a little workshop time on one day a month where she continues to do some monitoring and reinforcing of it with the patients. And our education council was collecting those sheets, looking at it, and reinforcing. But it's hard for frontline staff. I sympathize with that struggle because that council time comes once a month to have that dedicated time. Although I try to tell my people on councils, you're a council member 30 days of the month, not just during that 8 or 4 hour workshop time. But I really believe that they need support from their leadership team, 30 days a month to make sure that we're driving this process.
Thank you. I think this question is directed at Carilion. What sheets are you using?
So initially we had started off with the ASAP sheets. Those were a little bit more detailed and kind of challenging for some of our patients to understand and a bit more cumbersome to discuss. So we recently switched over to Lexicon. Their sheets are very patient-friendly. They're very focused on understanding the basics before you get into the heavy details and the more rare things. So we are very happy to say we're using the Lexicon sheets, and we haven't really had any struggles or questions come up. It's a quicker way to cover the meds while still covering the important parts.
Thank you. This question is for Dennis. How did you ensure compliance after your managers did away with the sheets?
So those sheets lived on the clipboards for over a year. We monitored them very closely in the beginning until we established that it had become part of the practice, and then still did monitoring of it, but less frequently. I'd say in late spring, early summer, we switched to a new documentation system for our nurses, and we were asking nurses to document their education in the computer. So I didn't do away with that sheet right away when it came, and there was a push too. But I said I need to see it in both places, that you're comfortable documenting in the computer, and that we can bridge that. So show me you can do it first, and then they did. And I say, in nursing, we always put things on our plates or get things put on our plates, but we rarely take it off. So at the end of the summer, I said, we've seen the practice. It's been over a year. We've held strong with it. It's consistent. I see it and I hear it, and I'm now seeing you document that education in iView. So we are going to take those sheets away. We did, and we didn't see our numbers drop. It was truly built into the practice. But had we done that 2 months, 3 months in, 60 days, 90 days in, it may not have been there quite yet. So it did take a full year of that.
Thank you. Could you speak more to how you were able to reduce falls in coordination with medication teaching?
I don't know if specifically, when I go in and I look at a patient's medications and those that were covered, I think we did a good job, as though we try to minimize those meds that may be related to falls, but also explaining those blood pressure pills, the diuretics, and the risk associated with them. But even more than that, I think that it linked, it changed something, the success we had with the Get Well Network changed something in our staff's mind. They felt before that med education couldn't be done with this population, and I think we also felt that falls are bound to happen with this population. You're going to have 5 falls a month. It's an ACE unit. We have a lot of confused patients. Many of our patients don't understand their risks. It's part of what we do. So when we changed that around with med education and said, no, it's not true. Our patients can understand, and we can be successful and can be the best unit in our system with this. We transferred that success and said, we've picked off the first thing. Let's make falls the second thing, and let's grow our success there, and we did.
Thank you. Dennis, we have another question for you. Did you change policy and procedures around med education? And if so, would you be willing to share?
We did not change policy and procedures around med education. We had a different ask on our unit, and it was just an internal, it was an expectation. If it was not you on your shift every day, it was always getting passed on, and the responsibility was going to fall to the next person. and then that person would be too busy as well. So we said that teaching and doing med education is a basic part of nursing, and we need this done with everybody every day. So hey, maybe that's the next step to make that a policy change. But it just became a practice change on our unit.
Thank you. At this time, there are no more questions. At the end of the webinar, you'll see a 4-question survey pop up on your screen. Again, it takes just 60 seconds, and we really appreciate your feedback. I'd like to thank our wonderful hosts from Carilion Roanoke Memorial Hospital and Christiana Care Health System for taking the time out of your busy days to share your stories with us. This now concludes today's webinar. Thank you, everyone, and have a great day.